Welcome back, everyone. Let's take our seats. We're gonna try and wrangle any stragglers from outside, but we'd like to get started on time so we have plenty of time for discussion. Deep breath. It's a lot of stuff. Okay, so I would like to take this time to invite our final panel moderator up to the stage.
So hi, everyone. I wanted to welcome everyone to the third panel of the day, Ensure Accountability, Equity, and Justice in Outcomes from Healthcare Algorithms. My name is Cora. I am the Chief Health Data Officer for the University of California Health, and I am delighted to be joined by three wonderful panelists today. And I look forward to hearing from them and also to the robust discussion that we will have after. So let me say a few words about our panelists in the order in which they will be speaking. First, Dr. Hoda Heidari. Hoda is the K&L Gates Career Development Assistant Professor in Ethics and Computational Technologies at Carnegie Mellon University, with joint appointments in machine learning and societal computing. She is also affiliated with the Human-Computer Interaction Institute, SciLab, the Block Center for Technology and Society, and the Institute for Politics and Society. Her research is broadly concerned with the social, ethical, and economic implications of artificial intelligence, and in particular, issues of fairness and accountability through the use of machine learning in socially consequential domains. Her work in this area has won several awards. Hoda co-founded and co-leads the university-wide Responsible AI Initiative at CMU, and is particularly interested in translating research contributions into positive impact on AI policy and practice. Second, Dr. Lisa Lehmann. Lisa is a primary care physician and bioethicist with a focus on AI ethics. She is Associate Professor of Medicine at Harvard Medical School and Associate Professor of Health Policy and Management at Harvard T.H. Chan School of Public Health. From 2000 to 2023, from 2020 to 2023, Lisa was Director of Bioethics and Trust at Google. And she has also previously held the position of Chief Medical Officer for the VA New England Healthcare System. Finally, Dr. Margaret Handley. Margaret is an epidemiologist and professor of epidemiology and biostatistics, as well as medicine at UCSF. She co-directs the PRIZE Center, which stands for Partnerships for Research in Implementation Science for Equity. She is recognized as a leader in the application of participatory and implementation science methods to improve health equity-related outcomes for populations that have experienced a disproportionate burden of illness or have been negatively impacted by social determinants of health. This past year, she was awarded a Fulbright to develop training in implementation science applied to climate change and health equity. And in 2022, she spearheaded a paper on risks and opportunities to ensure equity in application of big data and public health, with colleagues who are experts in developing equity applications for big data. Following what the other panels have done, we will be having 10-minute presentations by each speaker, followed by a Q&A session. Thank you. And with that, let me turn it over to our first speaker, Hoda.
Hello, everyone, and thank you very much, Cora, for the kind introduction. So today I would like to talk about a recent work with my colleague, Professor Alex John London, in which we model the ideal of beneficence for AI systems through the lens of the capabilities approach. So let me first clarify how this is related to the broader themes of this event, which are equity and justice in outcomes of healthcare algorithms. So it should be axiomatic that producing some sort of benefit is a necessary condition for the ethical and just use of AI. Without some associated benefit, there would be no way to justify the time, effort, and expense or the harms that cannot be entirely eliminated from developing and implementing of AI systems. And similarly, while some issues of fairness deal with the relationships of status and standing, such as equal respect and fair process, a large part of the debate surrounding fairness in AI so far has involved the distribution of the benefit and burdens of a technology. It is somewhat surprising then that as frameworks and tools for ethical and responsible AI proliferate, roughly half don't even mention beneficence or the production or conferral of benefit. Those that do frequently characterize benefits in broad strokes, some of which might accrue to certain individuals, some to groups, some directly associated with the operation of AI systems, and some associated with the economic benefit to the developers. At the extreme, some of these forms of benefits, such as the economic reward of selling AI systems, are consistent with the proliferation of AI applications that don't actually perform their stated task and do not provide a meaningful benefit to anyone impacted by their operation. Now, this is a major problem, which Dr. F.P. Wilson of the Yale School of Medicine has referred to aptly as the medical AI's Cassandra problem. And this is from a recent commentary. So for background, Cassandra was a key character in the tale of Troy. She had been given the gift of prophecy by Apollo, but the gift was tainted with a curse, that no one would ever believe her prophecies. Wilson argues that existing AI systems in medicine focus exclusively on accuracy to provide evidence of benefit, but there is often a significant gap between accurate predictions and the ability of a system to improve outcomes for recipients of healthcare services in the real world, or healthcare providers for that matter. Using a case study of a machine learning model designed to predict blood clots in hospitalized children, he argues that, and I'm quoting, "A prediction is useless if it is wrong, for sure, but it's also useless if you don't tell anyone about it. It's useless if you tell somebody, but they can't do anything about it. And it's useless if they could do something about it, but choose not to." Now, the broader point here is that it takes a great deal more than simply training a high accuracy predictive model to provide meaningful benefits to the target stakeholder groups, which often are providers and recipients of healthcare. Now, if the ambition of creating AI systems that empower and enhance human well-being and freedom is focused on individuals impacted by the system, then this amounts to the goal of ensuring that in their interactions with these individuals, AI systems meaningfully benefit them and allows them to and they function as assistive technologies. According to the World Health Organization, assistive technology is an umbrella term for systems or products that maintain or improve an individual's functioning and independence, thereby promoting their well-being. It is common to think of assistive technologies as systems designed for people with disabilities or who face other physical, social, or psychological impediments to their ability to function. And there is, of course, clear interest in developing AI systems specifically designed for the purposes of assisting such individuals. So for the remainder of my talk, I will take this as the running example for articulating and defending the precise criteria for assistance or beneficence through the AI system, which is the primary goal of our work. So at a very high level, for an AI system to be assistive, it must enable the recipient of assistance to better advance the plans and projects that actually matter to them. In the interest of time, and I won't go into the details of our precise formulation, I would just mention that we build on sense notation for representing the Amartya sense notation for representing the factors that influence an individual's ability to quote unquote function. And these have precise meanings. So we relate those abilities to the individual's freedom and describe how the choice to pursue certain activities from a larger field of possibilities relates to the individual's conception of the good life. With these building blocks in place, we define the criteria for AI to constitute a beneficent or assistive system as follows. An AI system is assistive or meaningfully beneficial if it enhances the stakeholders' ability to advance their life plans and well-being while upholding their fundamental rights. We also show how deviations from these criteria constitute several types of ethically problematic interactions with AI systems, including unjustified paternalism, coercion, deception, exploitation, and domination. Now, this may sound a little bit abstract, so let me provide a concrete example. Consider an older adult, Jamie, facing the early stages of physical and cognitive decline. Let's say Jamie could interact with a smart virtual assistance device to facilitate their day-to-day activities, such as grocery shopping, taking their medication on time, and automatically calling for help in case of emergencies. These are the kinds of functionings that would allow Jamie to live independently in their own house for a longer period of time, which might be part of the conception of the good life for them. Now, whether this AI system meaningfully benefits Jamie will depend on a number of factors. First, Jamie has access to a set of commodities and resources, including their housing circumstances, monetary wealth, and beyond. Certain characteristics of Jamie determine whether they are actually able to convert their available resources into a functioning that this system can provide. For instance, one such characteristic could include Jamie's current physical abilities. For instance, a strong enough voice might be one feature necessary to be able to interact with this virtual assistance device to order groceries, make calls, and so on and so forth. So here, Jamie has the freedom, if she has enough money to purchase this system, she has the freedom to decide how to turn their resources into functionings of their choice. For instance, whether to purchase the virtual assistant device or not. Such choices are frequently made by individuals with respect to their life plans. For instance, living independently as long as possible might be part of Jamie's life plans. But at the same time, they care about upholding their basic rights. For instance, Jamie might be particularly interested in ensuring that they maintain their privacy. If these are Jamie's goals and rights, then the virtual assistance device is not meaningfully assistive to Jamie if, first, it frequently fails to recognize Jamie's voice or movements, hence putting them and their health at risk. Or second, if it actually does the job of providing physical safety to Jamie, but at the expense of constantly surveilling every movement of them and sharing that data with Jamie's kids or companies with predatory marketing practices. So through this example, my goal was to illustrate how for an AI to provide meaningful assistance to the impacted individuals, it must satisfy at least two conditions. First, to ensure that everyone has the real freedom to pursue a distinctive life plan of their own. Everyone should be entitled to a set of rights, liberties, and social conditions that constitute the all-purpose means to be able to form, pursue, and revise a life plan. Martha Nussbaum, for example, identifies 10 central human capabilities to which all persons have a right in her view. The list includes life, bodily health, bodily integrity, senses, imagination and thought, emotions, practical reason, affiliation, and control over one's environment. For an AI system to be beneficial, it should not set back the individual's basic rights, in our example, right to bodily health and integrity. And second, it is, we argue, every individual's prerogative to decide among their preferred life plans and choose the functionings that best realize or express their conception of the good life. Now, an assistive AI system should not reduce the individual's ability to function in these ways. For instance, in the case of Jamie, if she values the privacy to bring guests over without the knowledge of their children, then the surveilling AI system described above violates the second principle. So for a more detailed explanation of the concepts that I talked about today, a precise description of these necessary criteria that I just went over, and also examples of the common failure modes to assistance and beneficence through the AI system, I invite you to take a look at our paper titled Beneficent Intelligence, which you can find on my webpage. But let me conclude by just saying that I argue that establishing beneficence is a key prerequisite to just and ethical use of AI in healthcare applications. The basic version of the framework that I presented here only talked about assistant at the level of an individual. However, the framework can be expanded to reason about assistance to larger populations through mass market AI products. And in such cases, one may define assistance with respect to common or average life plans of the target stakeholder group. One important factor that I left out was how to prioritize the competing interests of different stakeholder groups. For instance, the different stakeholder groups could be care providers, insurers, patients, taxpayers, and beyond. So in deciding what AI systems to build when these values and priorities conflict with each other, that's a question that I left out. And these are all important questions related to the justice and fairness of AI in healthcare that we hope future work explores through the lens of our framework. Okay, I will now hand it off to Lisa Lehmann. She is a primary care physician, AI ethicist, and associate professor of medicine at Harvard Medical School, and I look forward to the panel discussion.
Thank you, Hoda, for that really thought-provoking analysis and the insights that I think really pose some significant challenges for us as we think about the implementation of AI in healthcare in particular, and how we can make sure that the individual, that what we're developing is beneficial for the individual as well as the population when we think about implementing AI in the healthcare system and are focused on the population level. So I'm Lisa Lehmann, and I want to first begin by thanking the organizers of this conference, Keith and Ben, and everybody who put this together for an amazing day of conversation, and especially for all of the patients who are with us today, and the unbelievably refreshing experiences that you have been so wonderful to share with us, that I think ground us and really help remind us of why we're here and what we're trying to do, which was really, it's always about the patients and putting the patients at the center of everything that we do. So I have 4 points that I want to try and make today that hopefully you'll take away in terms of trying to answer this question of how can we ensure accountability, equity, and justice in our healthcare algorithms. And I'll try and go through them in a little bit more detail here. But the first point has to do with governance, in that if we are going to achieve accountability and equity and justice, that we need to really be attentive to governance. It's unlikely that self-regulation will be sufficient in this space, which is why I'm so grateful to Alondra and our colleagues who are working on the regulatory front, because I think that that's an important complement to this. And at the same time, as we think about deploying AI in healthcare systems, we need to develop strong mechanisms for local governance that are thoughtful and can really help move us forward. And part of that governance structure, I think, needs to be sure, first of all, that we focus on all the different stages of the life cycle of an AI system. And Ida Sims, when she spoke this morning, put up the AHRQ life cycle structure. CHI, an organization that I've had the privilege of working very closely with, the Coalition for Health AI, has also developed a life cycle structure in which they've also identified 5 different cycles, 5 different phases to the life cycle that I think are important to be aware of, because as we think about accountability, equity, and justice, the goal is to think about how each of those concepts can be operationalized throughout each phase of that life cycle. So when we're thinking about first defining the problem and being focused, as Hoda just reminded us, on beneficence, right? When we talk about what's the problem and is AI the right solution for that problem, we need to be thinking about, is this going to be beneficial to our patients at the end of the day? So that clarity and that challenge is oftentimes difficult. And sometimes people think just AI is this nice, shiny new tool and we should apply AI to it, but that's not necessarily in the best interests of our patients. So the governance structure can help us by thinking about defining that problem as the first phase, then moving on to thinking about the data. Right, data is critical, the critical next step in terms of thinking about that life cycle. What data are we accessing? What consent do we have to use that data? How have we prepared that data to ensure that we're going to be able to get the most out of it? And then how do we develop and assess those algorithms? What's the mechanisms that we have for validating training the algorithms on our local data and validating in the population that we're trying to help benefit. And then thinking about a small scale implementation, as well as how do we deploy it at scale and monitor it in an ongoing way. And those are the different 5 phases of the life cycle that I think we need to keep in mind. So as we're thinking about the governance structure and those different phases of the life cycle, I want to also suggest here, and this has already, I think, been articulated earlier in the conversation about how important it is to have a multidisciplinary group of stakeholders involved in all of those stages. And I just want to suggest that it's important for there to be diversity of representation at all of those stages, as we heard earlier in the who's designing the algorithms, and that we have ethics and equity involved at early in the development of the life cycle of the algorithms. To think that we should just approach ethicists or do an equity evaluation once something is developed really misses the point, I think, and ultimately, I think, delays the development of our products. So there's actually an argument to be made from a product perspective and from an efficiency perspective to thinking about how we can integrate ethics and equity early in the development and design of our AI systems. Our governance structure can also help us by focusing on and developing transparent methods of standards for transparent documentation. We had a great conversation this morning about explainability and what does transparency mean. There's certainly been a tremendous amount of work done in this space with regard to AI model cards. And how can we have transparency, kind of like a nutrition label, right? That's the model that we have. And you pick up a box of cereal and it tells you what are the ingredients and what are the calories, and there's a lot of clarity in terms of what's in it. And it's supposed to be understandable to the average consumer. And as we think about developing AI, we need to have those clear standards for what we're going to document. Where did the data come from? What's the data that's used to train our algorithm? Is it representative of the population that I'm trying to actually treat? And then the last thing when we think about governance, or one additional point that I'll make, is that I think we need some systems of certification and audits, as well as a registry of AI algorithms. And I know that in California in particular, there's an interest in having that kind of registry so that we can have clarity about what's happening, where AI is being used in our systems. But I think this also helps with the democratization of AI. If we have that registry and we have an understanding of how things have been validated and what populations they work in, that will allow us to extend the benefits of AI to other healthcare systems and other populations that may not have the same kind of infrastructure that UCSF has, or some of our academic medical centers that are developing AI systems. So that kind of registry is important, and that system of certification and audits will help also build trust. So governance is, I think, the first step to getting to accountability, equity, and justice. The second idea here is, and maybe I'll just say one other point here, when we think about systems of certification and audits, that there's an opportunity for organizations like the Joint Commission to step up. The Joint Commission that has a role in ensuring patient safety, they may be able to play an important role in this space in terms of certifying and auditing and monitoring of our AI systems in healthcare. The second point here has to do with data, and that ultimately we know we have a problem with data poverty. And part of that data poverty problem has to do with access to healthcare. Part of that data poverty problem has to do with lack of trust in healthcare. And I think at the same time, we need to acknowledge those problems and work hard towards overcoming them, while at the same time helping people understand what are the risks of not participating and not sharing data. So AI, I think, has that potential to reduce disparities if we've done well, if we do it well and we put into place mechanisms to assess for bias and ensure that our data is actually representative of the populations that we're trying to impact. But we're only going to get there if people are incentivized and understand the potential missed opportunities of not sharing data. We heard a beautiful articulation earlier today of the willingness of patients to trade off privacy potentially for sharing data that is actually going to benefit them. And so I think that there's an opportunity here to rethink our methods and how we can achieve better data quality, because we know if we don't have good data, we're not going to have good algorithms, and better representation of the data within our data system so that we have the diversity to overcome the disparities that currently exist in healthcare systems. So questions about how we can empower people to share their data and how we can incentivize that data sharing across healthcare systems so that we can develop better AI algorithms. Related to this is this idea of consent and privacy and security. And I think that there's some opportunities here for us to think about technological fixes like differential privacy that may help address our concerns about privacy from the outset of developing AI systems, and think about how we can maybe should be rethinking our notion of consent, and that does that model that we have in the research setting really need to apply in the same way when we're thinking about the use of aggregated data where differential privacy is present, and the risks of data sharing are minimized as a result of some of those technological solutions. So it's I think there's some interesting opportunities to rethink this in a way that is going to be beneficial to society and allow us to achieve the benefits for individuals. Okay, so in addition to data, the third point is operationalizing our ethical principles. So we've talked a lot about transparency as one principle. The NIST framework was put up earlier, and we have lots of different frameworks that have become, that have been developed and put out there. What these frameworks are missing, however, is specificity and some granularity about how do we actually operationalize these principles. What do we mean by equity? And actually, I love the definition of equity that was shared earlier. And I think it's important as we think about equity, for example, to challenge this notion that it should be equal performance across groups. And I realize that that's somewhat radical, maybe, but I think it has to do with how we contextualize AI with an AI system within the particular clinical context. What is our ground truth that we're comparing it to? What's the current standard of care? And how does the AI system actually improve upon that, even if it might not be equally beneficial across all groups? And I think what I'm getting at here, has to do with this concept of beneficence, right? Really, what do we mean? What is beneficial in this context? If we are benefiting the entire population over and above the standard of care, but we don't have equality across all groups, does that mean that we should not launch an AI system? And I'll give you a very concrete example of this that I dealt with in my work at Google, where we had an AI system for dermatology that used image-based machine learning where you could take a picture of a skin lesion, and it would give you information on whether your skin lesion was a melanoma, right? Was it skin cancer? But the challenge was that we had a dearth of data that was driving that AI model. And the AI model just was not as good in people of color as it was in people who were white. And in part, I think that was related to the dearth of data from people of color, and we worked hard to try and overcome that. It may have been related to the lighting in the camera and how that worked. But for whatever reason, the AI system was still better, even for people of color, than dermatologists. So if you have an AI system that is better than the standard of care, but it worked better in whites than it did in people of color, does that mean you shouldn't launch it if it's still better than the standard of care? So I think that's a question that we need to be, this is a workshop, and these are difficult questions that we need to really struggle with and have open conversations about in terms of what are the trade-offs here? How are we going to make decisions when we have that kind of trade-off and we're not achieving equity in the same way that we would ideally like to achieve equity, but it's still better than the standard of care where we're improving people's lives. Those are difficult questions, and I think that we need to think about it. We also, for example, know that there's sometimes trade-offs between fairness and accuracy. And I don't think we have a consensus about when we're willing to, move forward with something that may not appear to be completely fair, but is more accurate. And so, or we may not have the kind of explainability that we want, but we have more accuracy. So those are some questions about how we operationalize our ethical principles. And I hope, and I want to just also acknowledge here the work of the Coalition for Health AI, CHI, in this space where we're actually developing a rubric and much more detail about how we can operationalize these ethical principles so that healthcare systems can take this information and actually improve population health and integrate it into that governance structure throughout all the cycles, the life cycle of AI. The last point that I want to make is about system-wide training, because I think we know that technology only gets us so far, and it's really all about the people, right? And getting them to adopt the technology and to implement it into their workflow, right? And we know that if we have AI systems, but clinicians don't buy into it, or patients don't want that information, then we're not going to realize the tremendous potential and benefit of AI. So we need a lot of work here in terms of helping both clinicians as well as our patients understand AI. And ultimately, some of this AI is actually going to be automated, right? Right now, and this is maybe a little bit provocative too, right? We think about AI as augmented intelligence, right? And helping clinicians as a partner with clinicians as opposed to replacing clinicians. At some point, some of this is likely to be automated, right? And I think that's if you look at the history of medicine, right, we see many examples of this happening, right? We now have, when I trained in healthcare, I used to look at urine specimens under a microscope. Nobody does that anymore, right? I send it to the lab and I get an automated analysis back, and I trust that analysis. So there will be a point in time in healthcare where much of AI is, once it's validated and we have confidence in it and it's been tested, that we have confidence that it's accurate, even if we can't completely explain it. Clinicians, it will be automated, and there might not always be a clinician in the loop. And so I think that there's kind of an incremental phase here where right now we have clinicians in the loop, but we're going to get to a point where that might not be the case. And I think we need to think about how we're going to train healthcare providers and researchers in this space so that we can really leverage the benefits of AI in healthcare. So 4 points that I hope are going to get us closer to ensuring accountability, equity, and justice in healthcare: governance, thinking about data and getting better data, operationalizing our ethical principles with much more granularity, and thinking about how we're going to train our workforce so that we can really see these benefits. I'm going to hand it off now to Dr. Margaret Handley, who's a professor of epidemiology at UCSF.
Thank you. Thank you, everybody. Thanks, the organizers, for having this wonderful, thought-provoking session. And thanks to all of you for participating with your comments. So I'm going to keep along this theme about data. I'm going to share a big picture perspective that I hope will resonate with you. And it comes out of the way that I was trained in observational epidemiology. So I spent a lot of time thinking in the School of Public Health, where does the data come from? How do we understand how to reduce bias? How do we improve the validity of data? So in that space, I've always sort of been a questioner of data and what it represents for us. I've taken that thinking, I think, a lot further, and I want to sort of share some of those thoughts on that as they pertain to the present moment. So I feel like where we're at now is we have lots of data coming at us, and we're thinking about how to address it, how to deal with it, but we're not actually in it thinking about where it comes from. So I think I have a slide, if you can put that up. So what I was hoping to kind of get us to talk about a little bit is that we don't really talk about the position of data and the positionality of us in regards to data. And so I want to talk about that some. I want to talk a little bit too about how we can make data more virtuous, and I'll come to that. I think we've kind of addressed on this point a little bit in a few ways, but a colleague put it this way: there are 3 classes of approaches to prevent discrimination data. Make data less biased, that's what I'm mostly going to talk about. Build fairness criteria into algorithms. I think we think a lot about that, and that's important work. And then alter the application of the rules after the algorithm runs. So I really want to kind of dig into what is the data and where does it come from, and what can we do about that? So I want to talk a little bit about the ways we think we can get into big data and conceptualize it differently. And then I want to say a little bit about what are some of the tools in this space that can pertain to health equity. But mostly I want to talk about us and data and how we can make it more equitable. So I'm going to start from some observations from my position as someone with this data inquirer, or how to be bias, fixers, basically. And that's kind of influenced a series of questions that I'd like us all to think about and maybe talk about. So when I often have trainees and research people I'm collaborating with, some of the first things that I want to say when we're like talking about results is, who are the people in this, data? Who are we talking about here? Where did they come from? Why are they in this data? So who are the people in the data and how did they get here? I think this is a journey that is sort of the prequel to the algorithm journey. So why are we considering who is in the sample? How did this happen? These are kind of like fundamental epidemiologic questions. But I think if you take a look at them from an equity perspective, you start looking at positionality. How did this data get created? Why was it created? What was it used for? What is the value given to this data, and who got to decide what that value was? Why are we looking at it in the context of that value if we're not being open and transparent about how this data got here in the first place? So I think some of this idea too is, we've talked a little bit about sort of like when learning algorithms don't have the right training data sets, because they're not representative or people are missing from them. What we're really talking about is data absenteeism. And you could think of that as either forced, like people are excluded from the data, they were not included in the data, or people self-selected to not be in the data. And I think if we think about a lot of the issues driving health and the social determinants of health, there's a lot of reasons why thinking about these issues differently than who is not in our representative sample, but who has made a decision not to be in the data, or who has made a decision on someone's behalf to not include them in the data or do the work to get them in the data. So these are some of the things that I think we really need to grapple with before we're in the space of algorithm equity, but it's sort of like the prequel to algorithm equity. So I just want to say that again: who are the people in the data? How did they get here? Why are they in there? How did the value get attributed to them? Who got to give you the value of that data? Is that the right value for our questions? And what can we do to fix it? So these are sort of like the operational ones. I think, as we think about algorithms and this issue of like who's missing, I think it's sort of much more upon us to think about who is missing and why. So I'm going to talk about something that I think is one of my most important experiences I had. It was the first thing that I worked on when I came at UCSF over 20 years ago. So it was sort of like my realization that I had not the right idea about positionality in regards to data. I didn't have that way of talking about it at the time, but I realized the mistakes that I had made and I corrected them. I was lucky I could. So I want to share that story because I think it's really important, even though it's from 20 years ago. So I was investigating an outbreak of lead poisoning that was affecting a migrant community from Oaxaca, Mexico, who were living in Monterey County. In the work, I was analyzing a longitudinal data set, a very big data set with many years of accumulated data for all the children who were screened in the county. And I was spending a lot of time also at the clinic, and we were trying to develop a risk factor screening questionnaire for the prenatal patients so we could understand why was there so much lead poisoning. So I was both on the one hand looking at trends and trying to understand trends, and the other hand I was trying to make a risk factor screening questionnaire. Now about lead poisoning, all children are screened in certain age groups, and that puts you into a clinical protocol. If you have levels over 10 micrograms per deciliter, you're going to have follow-up. And so what I was looking at was children who had lead levels above 40 micrograms per deciliter who were in massive amounts of follow-up. They had many test results in the data set. So I was looking at not only a lot of data, but a lot of data per individual. And so this was influencing some things unconsciously in how I perceived the data and how I perceived the data I was going to collect. So this was already collected data. So what I wanted to do was move to the screening questionnaire because I was an epidemiologist. I just finished my PhD and I wanted to understand the problem so we could help fix it. And we were going to partner with the community, and that was really nicely established in terms of how the clinic saw their relationship to the community. So I think when I get to this point in the sort of narrative of this, there were two assumptions that I made. One was that the lab data was unbiased, and second, that the lead problem had value in the community because I interpreted all of those follow-up lead tests and compliant sort of, bringing children in for these pretty painful venous blood draws as buy-in for the problem, but that was wrong. So that was where I want to kind of go with this. So luckily, part of the project was to do focus groups with people who were affected in the community by the lead poisoning problem. We did these intentionally out of the clinical space and working with it was an indigenous language group, so working with people from the indigenous language group to conduct the focus groups. So I was focusing on how do we ask the questions for our survey? How do we make sure that we're capturing information in a thoughtful way? And yet we asked the question, what do you think about the lead poisoning problem in your community? And this basically changed everything because people said, well, I don't really understand what it is. It doesn't seem important to me. So we're like, okay, so why are you doing all the testing? Sort of bursting the bubble I had about like, everybody thinks this is an important problem. People are like, well, because someone's going to report us to Child Protective Services if we don't do it. And so I was like, oh, okay, so this is actually not at all what I thought was going on. So the reason I'm bringing this up is that I was letting this sort of like big data and my assumptions about the objectivity of this data, people had, a lot of data in that data system, and yet that had nothing to do with people's relationship to the problem. It had nothing to do with my position of thinking, oh, now I have an objective data set. When I move forward with collecting my own data, I will have an objective data set because people really care about this problem. So I think, in some similar ways, we're often looking at data someone else created for other reasons. We were talking earlier about the Obermeyer example about how one type of data was used as a proxy for something else in order to get at what people valued in terms of healthcare needs and unmet needs. But I did the same thing. You can just sort of see it from within because I was collecting the data. So I think this is a really important cautionary tale because we don't often get a chance to be the ones in the data. So what can we do to get more in the data? So what I wanted to sort of remind us about here is that if you have the chance to understand your position to the data and understand the positionality of people who made the data, what was the value they placed on it? How did it get there? What is your way of interpreting objectivity or what you think is the value of the data? And what can we do to sort of be more mindful of that and sort of augment what we do? I think Lisa was also talking about ground truthing. It's one of the things that I really value in doing. And sort of as we're talking about the life cycle of the algorithm, like thinking much more deeply about who gets to decide what variables are in the data. We were talking before also about community collected data. So not just hearing what I think is good in the data, but what do people think is important data on a problem that they think is important. So it seems very obvious to say those things, but you're often not doing them. We're not often not doing them. So what can we do to do a better job at that? So that's sort of in addition to the idea of once we've collected something, seeing how people react to it, making sure that we're sort of following, community goals, but at the same time, who gets to decide the data in the first place is something I want us to work on. So there are also tools that you can use in big data, and these are some of the things that in the paper that I was referenced before, my colleagues do really amazing work at. So one of them here at UCSF is Paul Wesson, and so he does a lot of work on how do you augment data when you've identified it's not representative. So what are some sort of methodologic strategies that you can use? Well, he has a lot of really good ideas for that, but I'm not going to go into them here. But like, there's a lot of ways that you can think about who's in the sample and who's not, and there's ways that you can sort of like enrich that sample through community-led data collection. So that's one thing I wanted to bring out. And then there's a lot of different ways people can think about analytic approaches too that are different than algorithms, but really sort of looking at validating things in the data through looking at them longitudinally. So I think there's some methods there that, especially in social computational data, are worth looking at. And one of my other colleagues, Yulin Win, has really done some amazing work on social media data. So my final quick hit topic is how, as a community, we create the pathway forward to think about some of the things we're talking about. We're talking about governance. We're talking about rules for tools. Like, I want us to be figuring out, like, what's the framework we're using here? Is this an ethical framework, a human rights framework, reproductive justice framework? Like, what are the frameworks that we need to own to have that kind of social contract with the data and our positionality as well as the data's positionality? So in closing, I just want to remind you of this first quote that I have. Facts all come with points of view. I think this is like one of the things that we can sort of bring to our work, is that we all come with points of view too. And so we come to the facts with points of view. What are the things that we need to do to create, whether we think of it as a checklist or a model or conceptual framework, to create the governance so that we are challenging information and how the value gets placed on it before we even get to the point of doing the algorithm justice work. So with that, I look forward to our panel discussion. Thank you.
Have a seat. Wonderful. And so let me actually jump right in to questions from the audience. We want to make sure we have time to incorporate thoughts from everyone. So are there any questions? I will start here. Monica?
Thank you very much. I really appreciated many of the things that all of you said. So weirdly enough, I have a question for all of you. So I'm going to try it, and they're different. Specific to beneficence and specific to how we should be thinking about that in this context. Do you have direct suggestions for us? Specific to the difficult and hard questions that we have to ask about the notion of the trade-off between fairness and accuracy. I was really struck, and I'm still struggling with the exemplars that you gave us around understanding, the dermatology exemplar. I wrestle with this a lot because my mind always goes to the retrofitted need for the harms and injustice that historically have happened. And so when we think about unfairly privileging folks based on clinical accuracy, it's always hard for me to think about that outside of the context of we're going to be over-privileging people who are already privileged. So I would love for you to wrestle with that. And then from this positionality piece, I'm struggling with something that I wanted to put in my remarks earlier, but I haven't heard it come up here today. And luckily, one of the patient advocates, Kate, got me to think about this, and that is, we act like we own the data. That like, I want to get into this data ownership piece. I want to get into this notion that these data actually belong to those of us who contribute to it. And I want us to really start to think about like that piece of this, because we have to allow people to opt out. And I'm not hearing a lot of that conversation either. So I'm gonna stop there, and anybody can respond to anything I've said.
Okay, thank you. Those were three meaty questions. So let's take them one at a time. Let's start perhaps with operationalizing beneficence.
Sure, I'm happy to take on that first question, and it's an excellent question. So for context, I would mention that the more I spend time with practitioners, people who are building AI to actually be used in practice, including medical applications, what we see is that things sound good when you're training the model, but when you actually take it to the real world, it fails miserably, right? So that was the context in which we started thinking about this idea of beneficence. When we come up with a model that sounds good, but at the end of the day, it's only good for the people who developed it. It doesn't help anyone, right? So that was the background from which we started this work. In terms of your question about how we can operationalize it, I go back to the point that Lisa made, and I think it's a very important one. I think beneficence is something that you've got to start thinking about from the get-go, right? It's not something that you can do after the fact. So my own work has been early on very much focused on bias mitigation once you have an AI system. But the more time I spend with, with actual AI systems in the real world, the more I realize usually at that point it's just too late, right? At that point you have already designed and developed an AI system that doesn't help the group that you aim to, or at least claimed to be trying to help. And then at that point, no matter how much bias mitigation you do, it's the system in its existence is problematic, right? So as a concrete solution, what we mentioned in our work, and we are actually trying to put together a protocol based on this, is this idea that when designers and developers of AI systems are at the thinking stage, at the stage of ideation, at the stage of deciding whether the cost-benefit analysis justifies creating this system, the idea is that this framework hopefully helps them think about, okay, who is the stakeholder group I'm actually hoping to benefit here? What is how am I helping them achieve some of the functionings that somehow contributes to their broader life plans? And then hopefully, if the answer to those questions are positive, once you build an AI system, then it is going to be at least, in broad strokes beneficial. Now you can think about the details of bias mitigation and so on and so forth. So it's a way of thinking that we think should impact the ideation stage first and foremost.
Thank you. Lisa, do you want to go next?
Sure. So the question of how we think about and make decisions about trade-offs, I think, is a fundamental ethical question, not just in AI, right? That's what ethics is all about, right? There's always going to be trade-offs in our decision-making in healthcare, and ethics is supposed to help us figure out what the right thing to do, all things considered, as we think about all of those different trade-offs. I think in this space, what we really need is much more public conversation and engagement to come to a consensus about those trade-offs. And I don't mean to minimize in any way. I think that these are very, very complex decisions. And at the same time, we ideally need to be making clear philosophical arguments, I think, that can ground us in terms of our approach. So when we think about some of those trade-offs between fairness and accuracy, or what I would call equity and population health, maybe, I think is one way of thinking about it. The question is, in my mind, is what's our overriding goal here? And part of the goal is, okay, beneficence. We want to benefit people. You can think about that as one philosophical concept. Another way of thinking about it is also from a utilitarian perspective, in terms of, are we benefiting? How are we going to benefit the largest number of people? And do we have an ethical obligation to do that if we can, while at the same time working to diminish the inequities in the system and in the system, so that we can narrow that gap and achieve equal benefits across all populations, right? So the idea of privileging a particular group, or if an AI system privileges a particular group, and the willingness to still deploy it, doesn't mean that at the same time we shouldn't be working very, very hard to raise everybody up to that same level. And so I think it's a question of what, going back to, what are your ultimate goals? Are you trying to improve the population health? And can we even engage in a conversation with those who have been most marginalized about the reality that this system, even if it doesn't raise them up to the same level, and we don't completely close the gap in terms of benefit, we are still benefiting them more than the standard of care. So, and I think that's part of the challenge is, to put it into the whole context, and to have the whole picture, and to understand, well, what are the alternatives here? And is using an AI system that may not be as fair or equitable as we would like, still be better than what exists. And maybe we're saving lives by using that AI system, even if it is not as good it's not equally good in every population. So I know that that's a challenging thing to get your head around, but I want to encourage us to tackle that and have an open conversation, and would love to hear different perspectives on that. Maybe that historical concern, is that significant enough to inhibit us from deploying that system that still may benefit that population? I just want to add one also parking lot kind of idea. We've talked a lot about data here, and what we haven't mentioned was the idea of synthetic data and some of the ethical issues around synthetic data, because I think that one of the potential solutions to our data problem is the generation of synthetic data, and I think we're going to see more and more of that. So it might be worthy of some thought also.
Thank you. I absolutely agree that more conversations around these difficult issues are critical. So Margaret, do you want to tackle the opt-out question?
Yeah, no, I think we need a lot more ways of thinking about not having researchers and clinicians be the gatekeepers of data, and somehow like an us and them around data. So there's a lot of ways I think that are exciting that we can start to approach that, but it requires, I think, many on-ramps and pathways for that. So one is, why are we not having data literacy skill building in our educational systems? Why don't people think that they own the data in the first place, that's their data? Why are we creating ways that data only comes to people when they're in vulnerable positions in their healthcare setting, and then the information becomes relevant to them, but it wasn't before? Like, why is that how we set up our educational system? Okay, so that's like one that I work on and I really find important. And along those lines, what are the ways that people in communities create their own data all the time, but don't necessarily, quote, make a data set of it? So, like I work a lot with people who are using WhatsApp to like text all their friends and figure out if they're going to wear masks for Thanksgiving. And then we make a graphic of it in English as a second language classrooms. And we talk about that. Well, that's a data set they made. And because they made it, they feel they're in it and they feel it belongs to them. And therefore they might want to actually do things. Our hope is that we will help people become more like data advocates in their communities for issues that come to them. But where does that come from? Like, does that come from an educational system? Is it come from a healthcare system? Like, where do we own that obligation, I think, as a society, to just make it part of what people do, so it's fluid, so that it's not like this big wall exists between like information infrastructures and people's daily lives. So those are just some ways that I sort of focus a fair bit on the education system as a way of in early life having this be a natural process for people. But we certainly can be bringing it into many different communities. Why are we not doing that in as people who are more familiar with the language?
Great, thank you. Do we have a question from the online?
Oh, here, All right, so this question is from Stuart Dan online. He is asking, what are your thoughts about defining the problem and designing AI tools with the goal of increasing health equity, which would include approaches such as weighting the training data according to the needs of stratified populations? For example, more need gets more weight in the model, less need, less weight.
I'm happy to start with that. I like the idea of thinking very carefully about who's in the sample and what they represent. So, if that's one of the approaches that helps answer a specific question, I think we can try out, I think, different ways of looking at weighting. One thing I worry about that is the variables for which that weighting is constructed. So I want to make sure that not aggravate a problem. I think, there's a lot of risk we've identified already with sort of racial profiling in data to do weighting and things like that, and algorithm training. So I would just want us to be very thoughtful about what we were trying to create, and perhaps not rely on one approach only as we explore how to do that work.
Thank you. Others? Okay.
Thank you.
Thanks.
Great talk and very insightful talks. So my question here is regarding, so in addition to data fairness, my name is Karthik and I'm working as a specialist at Berkeley Lab at UCSF. So coming back to my question, so in addition to data fairness, I wanted to ask you about a different factor, that is model safety, because in this LLM revolution, we see that people getting polarized into two groups. Some people favoring for the open source models and the other people favoring for the proprietary models. So when it comes to the clinical domain or the biological domain, what should be the right framework, or even this model safety a factor to include when we discuss about this equity and the algorithmic justice? And Lisa, especially since you worked with Google and all, I know that Google has deployed some of their algorithms in clinical settings for diabetic retinopathy detection and all. But are all those models open source, or is it still accessible only for the Google folks? So what should be the right framework if you, at the deployment level, should the model be accessible to the public or just for the?
Great. So I think you're asking a couple different questions in there, if I understand it correctly. So one has to do with model safety. One has to do with open sourcing models. And then a more specific question maybe related to that in terms of Google's policies. So with regard to ARDA, the diabetic retinopathy AI system that Google has deployed and used, especially in low and middle income countries, which is a image-based machine learning method to read retinopathy scans and try and address the problem that we don't have enough ophthalmologists, right? We don't have enough healthcare providers to read these scans, and if we can do it in an automated kind of way, we can then triage people who really need care early and immediately to get that care, so that we can improve patient outcomes and prevent blindness, right? So it's trying to address a huge healthcare problem. Google has actually, I don't want to misspeak here, and I'm not, let me be clear, I don't work for Google anymore, and I don't represent Google's approach to this. But my understanding is that Google has has taken the approach of licensing that technology, and it's actually integrated into some microscopes, or into scopes that are not microscopes, but into scopes that are doing the images to help with it. So there are cameras that actually have the AI integrated into it, so that it's actually being used in ways that can help people. Whether or not some of that is also open source, Google has a tremendous history, I think, in a very, very positive way, of open sourcing a lot of its technology. And so you'd have to look online and see, is some of that also open sourced? In terms of model safety, absolutely, I would say that is a core ethical principle that should be driving our decision-making about when we launch an AI system in healthcare. Ultimately, that goes back to our professional value and ethic of do no harm, right? And ensuring that our healthcare systems are safe. And that's part of that. The reason why, when we think about the life cycle stages, one of those stages is like a silent deployment, where we're deploying an AI system in a clinical setting to gather data about safety and to assess if, in fact, the model is doing what we expect it to do, to be able to assess, are there data shifts? Is there bias here? What might clinicians do with the information? Are they going to ignore it? Is there a fatigue alert associated with it, alert fatigue associated with it, which we know happens in healthcare settings, and how we can implement it into the clinical workflow so that it does achieve its goals in a safe way. So I think safety is, when we're talking about the healthcare environment, is a very, very significant and important factor that needs to be in our minds. And the governance structure that we develop has the responsibility for ensuring that safety for our patients.
Thank you. Okay, I actually think we are, we could take one more? Okay, we could take one more. So how about third row, center, third row, black center, yes. You had your hand up first.
Nora Hazen-Voss. I'm a project manager at ImmunoX at UCSF. It's like an academia and pharmaceutical collaboration space. I'm wondering where you see the integration of data, because I'm seeing like different buckets that it could come from: electronic medical record, Google, clinical trials, tech companies, government even. And even within the electronic medical record space, it's so siloed between different hospitals. Like I used to be a clinical research coordinator, and it used to be really hard to get medical data from a patient that's being seen at Stanford versus just at UCSF. So how is this data being fed? Where is it being fed to? Is it open AI? Is it, you know, tech company's algorithm? Just kind of big picture questions of what you think about that.
Sure.
So great question, because data is at the core of our ability to develop these algorithms. Let me just like sort of focus on healthcare data, right? And I think that my vision here, I guess, or what I'd like to see is patients, all of us, right? We're all unfortunately going to be patients at some point, and really being empowered to have access to our own data, all of our data. And I think some of the work that colleagues in Boston, Tom Delbanco spearheaded with open notes was the beginning of that, giving patients access to their own data and empowering patients to share that data with whom they want. And when I say all of their data, multimodal data, right? My radiology images, my echocardiogram images, my electronic health record notes. It goes back to the question of prioritizing equity, right? What we can do in terms of looking at notes in terms of social determinants of health and being able to do work with that from an AI perspective is phenomenal in terms of the potential there. So ideally, patients, I think, people should be in control of their own data and be able to share it broadly. And at the same time, I think as a society, we need to do a much better job of educating people about the value of that data and understanding both the benefits and the risks of sharing that data. We need to create mechanisms for more interoperability across healthcare systems. We need to figure out how to make sure that healthcare systems are not just holding on to patients' data so that they can monetize it, so that they can leverage it, but really thinking about how we can use that data for the good of society and for all patients. So I think there's lots of opportunities here. I was actually just so excited to see actually that for those of you that have an iPhone, Apple in its Health Kit now has, you can download all of your data through Epic from your healthcare system onto your iPhone, and you can share it with whomever you want. Google was also working on something similar for the Android health system. I'm not sure exactly where that's at yet, but that is a huge step forward in my mind in terms of being able to share data. And when we think about generative AI and the opportunities of AI here in this space, OpenAI, I guess, just released a model that deals with multimodal data. So the ability to work with all this data is going to be greatly enhanced. So it's a very important question, and we have a real problem with the current incentive structures, as well as the infrastructure for sharing data that we need to work on and improve.
I just want to make a couple comments too. I think, that's all really true and good, but I do worry when you think beyond kind of like a clinical data system about integrating different types of data that may have been made with very different values. And so I think the idea that all data is equal and we have all this data gushing at us, and if we can access it, and then there'll be other benefits of that, I totally agree with that. But on the other hand, I'm like, well, but if data is there because it's for billing, and I work at a safety net hospital, and like the way billing happens is different in different systems. And so what do we value when we look at certain types of data? What are the ways variables are constructed? Which one has hierarchically like more value in what we're doing? And how do we come up with like ways of explaining that to ourselves that make us do due diligence? I think about like, what does equity look like when you have data integration with variables that may not come from the same value system?
Okay, so with that, I think now we are at time. So I just want to thank the panelists for your great presentations. Thank everyone in the room and online for participating in the discussion. Lots of very difficult questions and important things that we need to work through, I think, together in order to achieve many of the benefits that we've been talking about today. So thanks to everyone. And I think now we're going to be turning to some breakout rooms, right?
Almost. We've got one more.
Sorry.
Sorry. We have one more poll for you all. So that should be active now. See if I can get it pulled up here. There we go. Okay. So one more question, similar to the previous two panel questions. It's a ranking of potential policies and practices. I'll give you guys a few minutes to respond to this. I'll just remind you again, it's at slido.com. Enter AJ workshop. There we go. A few more people. That's good. Just give it about 5 more minutes. But I'll remind you again, there is an open text box there in case there's something that we missed. Please put your thoughts in there. Okay, I'm seeing some eager faces, so I'm just going to go ahead and show the results because I think we might be done with this polling portion. Let's just together see what the number one selected policy and practice appears to be fairness standards. That's not surprising, but that's great. Again, these are all important. We recognize that, but we do have to make decisions based on resourcing. Fantastic. Thank you all so much for this. I'm going to invite Gretchen to come and tell you about the afternoon session.
Hi, I'm Gretchen Kaiser. I head up the Research Development Office in the Office of Research here at UCSF. And I just want to thank all the participants from the first part of today's workshop, the panelists, the moderators, Dr. Nelson, and all of you for contributing, and all of those online. We're going to close up our online version of today's workshop. And I just want to, before we fully leave everyone, I'd like us to just keep in mind kind of three things about today's workshop in general. One is that we hope out of the workshop and people's participation and hearing things, many of the important things that have been surfaced, that we gain an increased understanding of the complexities of this interface between algorithm and health equity, algorithm use and health equity. The second thing is that we also come to a greater understanding that we all have different perspectives that need to be included in this. And it's valuable that we hear these different perspectives as often as we can. And the third thing is that as we've heard so much from our panelists, and we hope to get increasingly this afternoon in the breakout sessions, really granular types of articulation of the challenges at hand and some of the proposed solutions, whether they be simple, easy things that we could think about doing relatively easily, or they might be bigger things that require significant institutional, significant government investment, but for us to take the opportunity to bring these to light. So with those three goals for today's workshop, I'd like to thank the participation of those online and wish you a good afternoon. And then I'd like us to move literally to a deeper discussion in discussion breakout groups this afternoon. And for us to talk about, again, with some granularity and some specificity, the challenges of fair algorithmic practices in precision medicine.